Hi everyone, welcome to the GlucoCare training for Citrus Valley Medical Center. By the end of this training course, we would like you to be comfortable knowing which patients are appropriate for GlucoCare, the situations in which GlucoCare should not be used, and we'd like you to be confident that you know how to manage your patients on the GlucoCare computerized insulin drip software. So to start, we just like to recognize that we understand insulin drips are very complicated and they're also very time consuming for the nurse when they're managing a patient on an insulin drip. But we wanted to emphasize the impact of hyperglycemia and how managing that blood sugar can improve patient care for our hospitalized patients. And number two, we just wanted to go over the strategies that we have available at our fingertips to help us manage blood sugar. This intention of this course is to focus on critical care patients, so we're going to be focusing on insulin drips. Okay, so to start, why do we care about hyperglycemia in hospitalized patients? We know from literature that patients with diabetes mellitus are more likely to be hospitalized and they're more likely to have a longer hospital stay. We've actually looked at this data within our own population. What we've seen is that patients with diabetes who are uncontrolled, um, they're they're likely to have a 1 day additional length of stay compared to their non-diabetic or their diabetic but controlled um, counterparts. Now, just a side note, all of the references for each slide are located at the bottom of each slide. So this particular statement came from ACE, American Academy of Clinical Endocrinologists, in 2009. So what they said is hyperglycemia in hospitalized patients, irrespective of its cause, is unequivocally associated with adverse outcomes. So what does that mean? So they don't just have to just have diabetes. So we're talking about a patient, for example, like an open heart on vasopressors with high blood sugar. If we control that blood sugar, if we manage it well, probably with an insulin drip, then we are going to improve the patient's outcomes. We're going to reduce their risk for adverse outcomes. Okay, so and why is that? So we know that hyperglycemia increases the number of hospital infections by impairing leukocyte function. It impairs wound healing by impairing collagen synthesis. And it also places the patient at a prothrombotic or inflammatory state. Now, managing blood sugar is not just good care for patients, it's also good for our hospital. Diabetes is a financial burden. There was a 2007 survey that estimated that 22% of all hospital inpatient days were incurred by patients with diabetes. And when we think of diabetes, we a lot of times think of this as an outpatient disease, and in some ways it is, but in reality, inpatient care actually accounted for about half of the 174 billion that was spent for the disease. So we're seeing a lot of these effects in the hospital as well. Okay, so which patients are appropriate for insulin drip therapy? So the recommendation, and this comes from ACE, is for patients with sustained hyperglycemia, and we're going to define that as greater than 180 milligrams per deciliter for at least 2 consecutive values in critical care units, may be a good candidate for an insulin drip therapy. Now, you have to look at the patient as a whole. Maybe this patient just had a single dose of steroids and their blood sugar went up, and maybe it went up for a couple values, but you see it coming back down. Maybe that patient is not appropriate. We're talking about a patient who has a sustained hyperglycemia and related to their disease state. So what we'd like you to do is kind of recognize those patients, kind of see, I have a patient who has consistently high blood sugar. I think we can improve this patient's care with an insulin drip. And then we can discuss with our physicians and have a great conversation where we look at ways to help our patients better. Two, so there's no insulin drip that's created for patients who are eating meals. Every single insulin drip is intended for a patient who's either NPO or who has some type of continuous nutrition source that's not variable. So we're talking about like a continuous tube feed or a TPN. And the reason is because insulin drips can't predict when you're eating meals. It'll increase the drip rate, and as the food is digested, as it moves out, insulin drips generally don't come down fast enough, so you place the patient at risk for hypoglycemia. So there are some ways to try to get around it, but our preferred method is for all patients who are eating meals or who are on bolus tube feeds to use some type of basal nutritional therapy or basal bolus therapy. All right, and then lastly, which patient is appropriate for insulin drip therapy? Patients with a potassium level greater than 3.3. The reason is insulin is going to pull potassium into cells, put the patient at risk for arrhythmias, cardiac, other various adverse outcomes. If the potassium level is lower than 3.3, it must be corrected before we start an insulin drip. So, so if you have a patient, make sure you check that. Make sure you check the level to ensure that it's greater than 3.3. If it's not, then we need to make a phone call to the physician to make sure they know about that, and we correct that before starting. A lot of times, we'll have to also run potassium continuously while the patient's on the drip just to maintain it. Okay, insulin drips are not created equal. This was a study that was done in 2007. They did a review of 12 different protocols. Just glancing at these, they actually put these side by side. I think this is a really great way to depict this. Even the target blood sugars weren't consistent between all the different protocols. So you can see here, 100 to 150, 120 to 180, 90 to 144. It's like there's no agreement on that. Whether you give a bolus insulin dose at the beginning of therapy was not consistent. Many of them did not do that. Whether you give boluses throughout the drip as it's running, also that wasn't consistent. And even some of the ones that gave an initial bolus dose, they didn't give bolus doses as the drip was running. And insulin drips sometimes take into account the direction of the change, the velocity. So how fast is the sugar decreasing once you start the insulin drip? And some of them look at insulin resistance, but not all of them. So you can see there's a lot of differences between the different insulin drip protocols that are available. It came out of that same 2007 study. And what they did is they took a graph, a hypothetical patient with different blood sugars, and they ran the protocol through these patients and just saw how would that insulin drip recommendation, dose recommendation changed as the blood sugar changes. So you could see that there's a wide range of insulin drip rates that are starting based on these different protocols. It starts anywhere between, looks like about 2 units per hour all the way up to about 18 units per hour. As you go to the next one, you see some increasing, you see some decreasing. When you get down to where you're actually hypoglycemic, there are actually 2 of the protocols that are still running insulin at that point, but most of them are shut off. So so there's a lot of different insulin drips out there. So which ones are we going to use? All right, so back about a year and a half ago, we piloted the GlucoCare computerized insulin drip software. This is an FDA-approved, evidence-based insulin drip therapy, and this was based off of the Yale protocol. So far, we've had great success, and we actually brought this on for the institution because it works so well for our patients. The nice things about it are some of the pluses. Is this is a cloud-based software, so it can be used on any device, meaning you don't have to install any software on the computer you're on. You just need to open up a web browser and point it towards the software, and you can start using the insulin drip software. All calculations, so that we're talking about initial calculations and all adjustments, are done automatically by the computer system. And because it's a computer system, it also has the ability to give alerts. So it can alert the nurse when a blood sugar check is due. And it can also adjust the frequency of rates when your patient is at risk for hypoglycemia. So if the blood sugar drops too quickly, it can adjust that rate. So you check it faster and you make sure you avoid that hypoglycemia rate. So we've used this for, like I said, about a year and a half now. And what have we seen? We've seen a very low hypoglycemia rate. So for patients that have been on protocol, our hypoglycemia rate has been less than 0.02%, which with our previous protocol, our hypoglycemia rate was about 2%. So this is a big improvement. But that doesn't mean we're sacrificing efficacy. So the average blood sugar for for all patients that were on the protocol is 145.3 milligrams per deciliter. So that's excellent. But not all patients are appropriate for GlucoCare. So which are not appropriate? So we're talking about diabetic ketoacidosis, hyperglycemic hyperosmolar syndrome. Generally, these patients are complicated in that they also have strong or important electrolyte and fluid management needs. Insulin is not necessarily the top priority. It's important, for managing these patients, but also managing the electrolytes and fluids is just as important. In these situations, GlucoCare may start off a little bit non-aggressive enough and maybe a little bit too aggressive in the end. So for these patients, it needs to be managed by the physician directly, and there are some ADA protocols out there that can help guide therapy. If the blood sugar is greater than 500 milligrams per deciliter, the GlucoCare system will not let you start an insulin drip on these patients. But if you start this patient, if you give some sub-Q insulin and you correct the blood sugar and it goes under 500, then GlucoCare may be used. So it still is an option, and just keep that in mind. All right, pediatric patients, we're not using this. And patients, as I stated earlier, who are eating meals or on bolus tube feeds. And I put an asterisk next to this. Sometimes we start a patient on GlucoCare, and sometimes they order a meal, and sometimes they don't tolerate that meal. So if the physician wants to keep the GlucoCare running for a little bit and see what happens, that's fine. But once they really start eating meals, at that point, we should do an IV to sub-Q transition off of the software. And for all of these situations above, we need the physician to be involved. We need them to order and define parameters for like diabetes, for DK and HHS. In this situation, we need the physician involved so they can help us correct it less than 500 to where we can use the GlucoCare software. And that's it for the first part. So after this, we're going to go into how to use the software.